Welcome to the deep dive. Today we're plunging into something, well, frankly startling about cancer care right here in the U.S. Get this, only about 7.1% of cancer patients are currently in clinical trials.
That's right.
But, and this is the kicker, estimates suggest up to 50%, half, might actually be eligible.
It's a huge disparity.
It really makes you stop and think. Half of eligible patients potentially missing out on advanced, maybe even life-saving treatments. So our mission for you, the listener, today is to unpack this. Why this surprising underutilization? What are the barriers keeping patients away? And crucially, how can a new collaborative approach start bridging these gaps?
Yeah, that's the key question.
We're digging into insights from a strategic messaging framework for a company called 1104Health. They're working on transforming cancer care. Our goal is to give you a real shortcut to understanding this vital topic. Okay, let's get into it. The source hits us immediately with this stark truth. Clinical trials, often the source of the most advanced treatments, are just drastically underused. Why? What's the fundamental reason for that?
Well, what's really fascinating and a bit concerning is that the core problem isn't necessarily a lack of trials themselves. It's more about an entrenched, almost, you could say, outdated mindset.
An outdated mindset. How so?
Trials are often viewed as, well, as a last resort, something you try only when everything else has failed. They aren't typically seen as an integral part of patient care right from perhaps an earlier stage.
I see. So it's a perception issue.
Exactly. And this perception, this misconception, it has huge consequences. It creates bottlenecks. It limits access for patients who could benefit right now. It slows down medical innovation because trials can't recruit effectively. And tragically, it means patients are left without potentially life-saving options.
And who bears the brunt of this broken system?
Well, you have patients, particularly those with rarer or more advanced cancers, and their caregivers. They often feel like they fall through the cracks. Imagine being a caregiver already completely overwhelmed, trying to navigate these incredibly complex, dense databases online.
Must be daunting.
It is. They're desperately searching, often never even hearing about a trial that could be a perfect fit, that could offer real hope. These outlier patients just get lost.
And what about the doctors, the oncologists on the front lines?
The referring oncologists, they're really the heroes here, doing incredibly demanding work. But they face enormous problems trying to connect patients to trials. Our sources point to sort of three main roadblocks. First, just sheer time.
Time.
Yeah, researching trials, coordinating referrals, it's incredibly time-consuming. You can almost hear them thinking, I just don't have time to sift through hundreds of trials. My focus has to be on treating the patient in front of me today.
That makes sense. Patient care first.
Absolutely. Then there's a financial risk, or at least a perceived one.
Financial? How?
Many community oncologists worry about losing the patient if they refer them out to a trial site, maybe an academic center. There's no guaranteed return for their practice, and they often feel uncompensated for the significant effort involved in just finding and pre-screening patients for these trials.
So it's a practice management concern too.
Precisely. There's a quote in our source that captures it. If I send my patient to a trial, I may never see them again. That's not good for them or my practice.
Wow.
And another stark one, I don't get paid for this work. It highlights the lack of clear incentives.
And the third roadblock, you mentioned mindset earlier.
Yes, that outdated mindset pops up again, even among some oncologists. The view persists that trials are purely experimental, really a final last-ditch option. It's not always seen as a standard or even early-stage care pathway.
So they might think trials are only for when standard treatments fail.
Exactly. And there's often no easy way to explore options earlier, as one sentiment puts it. The infrastructure isn't there to make it simple.
This sounds like a ripple effect. Who else is impacted?
Oh, definitely. Pharmaceutical companies and trial sponsors feel this acutely. They're trying to develop new drugs, championing innovation, but patient recruitment is a massive bottleneck. It delays drug development, costs billions. Billions, because they can't find patients fast enough. Largely, yes. They often rely on older, fragmented outreach methods that just don't connect effectively with community oncologists and their patients. And then you have the principal investigators, the PIs, the subspecialists doing the research. Brilliant minds, but they often lack direct access to the right patient populations. They struggle with manual networking, trying to find colleagues who might have suitable patients. It keeps trials siloed, inefficient.
And what about insurance payers? Are they part of the problem or potentially part of the solution?
That's a great question. They could be powerful allies. But often, the current reimbursement structures inadvertently create disincentives for trials.
Also,
Well, the models tend to incentivize standard of care treatments more heavily, so financially it might seem less appealing to support trial participation, even though better patient outcomes from trials could actually reduce overall healthcare spending in the long run.
so the financial incentives aren't aligned with the potential long-term benefits.
Often, no. It's a system where different parts, even with good intentions, can end up working against each other.
So it's clearly not just one thing, but a whole web of interconnected issues, a systemic problem.
Absolutely.
And as our source points out, this already tricky situation is getting even tougher because the field of oncology itself is changing so rapidly. This is where it gets really interesting, right? How is this changing landscape putting even more pressure on this old way of doing things? Why is adaptation so critical now?
That's a really important point. Community oncologists are feeling this pressure intensely. Our sources highlight several key shifts happening simultaneously. First, just the sheer complexity of trials and treatments is exploding.
Exploding.
Yeah, we're seeing this rapid rise in incredibly novel therapies, think cell and gene therapies. Those now make up about 25% of all oncology trials, a quarter.
Wow.
And we're dealing with more complex cancer cases overall. Maybe 20–30% of the over 2 million new cases each year are highly complex.
Okay.
Plus, the number of trials has surged over 6,500 active in 2023. And these new trials, especially for targeted therapies, often have incredibly specific, stringent eligibility criteria.
Making it harder to find the right patient for the right trial.
Much harder. Then second, those patient recruitment challenges we talked about, they're persistent. Despite more trials, we still have that low 7.1% participation rate you mentioned. When maybe 50% could be eligible, access is a huge piece of this.
Access meaning location.
Yes, physical access. Around 55% of cancer patients simply don't have a relevant clinical trial available at their local hospital or clinic, especially true in rural areas.
That's a massive barrier.
It is. And finally, there are mounting financial pressures from all sides. New cancer drugs are incredibly expensive globally. This puts an urgent emphasis on needing efficient trial processes to evaluate these costly treatments properly and quickly.
So for the community oncologists listening, the pressure is immense.
Absolutely. There's this huge pressure to stay current, to integrate trials into care. But the existing system's fragmented, time-consuming, based on that old mindset, they just aren't built for this new level of complexity.
It sounds like trying to navigate a superhighway with a horse and buggy.
That's a pretty good analogy, actually. The tools don't match the task anymore.
Okay, so given these mounting pressures, the system is clearly strained. Is there a better way?
Yeah.
This brings us to what our source material presents as a potential solution. 1104 Health's vision, what they term the promised land of cancer care, built around a shared care network. What's that about?
Right. At the heart of this vision are some really powerful core beliefs. First, patients deserve every option. This means access to advanced treatments like clinical trials shouldn't be a luxury. It should be, well, fundamental.
Okay, makes sense.
Second, collaboration drives better outcomes. The idea is fostering partnerships across the system between community oncologists, specialists, trial sites, improves care, and builds trust.
Collaboration instead of silos.
Exactly. And third, critically, trials should be integrated into routine care. Not as a last resort, but as a readily available option that enhances patient care without breaking that crucial doctor-patient bond.
So moving away from that fragmented model.
Precisely. It's about creating what they call a transformational story, moving oncology from fragmented care towards genuinely collaborative solutions.
And the vehicle for this is the shared care network.
That's the new game, as they put it. The shared care network powered by 1104 Health. Think of it as an oncology collaboration network. It's designed specifically to empower physicians. How? Through digital collaboration tools, much more streamlined referrals, and ways to enhance this kind of episodic care, like a trial. But, and this is key, without disrupting that existing trusted relationship between the doctor and their patient.
That seems crucial for oncologists.
It is. The big vision here is, and I'm quoting their goal, a world where every patient gets the right trial at the right time in the right location without oncologists losing valuable time or their patient relationships.
Okay, so what does this network actually do for the oncologist? What are the features?
It provides a whole suite of support, basically designed to lift that burden we talked about. There's trial matching technology to help quickly find the right trial without the guesswork.
That addresses the time issue.
Right. Then, collaborative care planning tools to work alongside disease specialists, maybe at academic centers, to map out the best treatment path. Physician-to-physician consults, easy ways to get expert input, maybe a quick medical record review from a specialist.
So tapping into broader expertise easily.
Exactly. There's also patient navigation support, help for the patient themselves, guiding them through the complexities of enrolling and staying engaged in a trial. A streamlined referral process, making it simple to refer, track progress with minimal administrative hassle.
Left paperwork, more focus on care.
That's the goal. And finally, on-demand education, quick, bite-sized updates on the latest treatments and trial findings, helping them stay current.
This sounds like much more than just, a searchable database like clinicaltrials.gov.
Ah, you've hit on a really key point. That's their big differentiator.
How so?
Clinicaltrials.gov is essentially a massive static library. It lists trials, but it doesn't actively help you enroll a patient or manage the process. 1104Health emphasizes what they call hands-on concierge support.
Concierge, like a hotel.
Sort of. It means they don't just give you a list. They deliver curated, relevant trial matches to the oncologist, and then they actively guide the doctor and their staff through the often complex referral and enrollment process.
So it's active support, not just passive information.
Exactly. It's not just a tech tool. It's a collaborative network offering tech-enabled, hands-on partnership. They use terms like white glove concierge support. The whole idea is to drastically reduce the friction, the hassle of getting a patient into a trial.
And this concierge model helps prevent that feeling of losing the patient after referral.
That's a core aim. It's designed to counteract those pitfalls of traditional referral models. It ensures the referring physician stays connected, gets updates on their patient's progress, so they don't just feel like they've handed the patient off into a black hole.
Okay, so let's connect this back to those barriers oncologists face. How does this network specifically address them?
Right, let's tackle those head on. First, that fear of losing patients. The network's message is clear. Trials are episodic care, not a handoff.
Episodic care, meaning temporary for a specific purpose.
Exactly. The shared care network is built to ensure coordinated care. The patient participates in the trial, and then the system helps ensure they return to their primary oncologist who's been kept informed all along. Full transparency.
Addresses the losing the patient fear. What about time and compensation?
The system is designed to handle the heavy lifting. The concierge support, the tech. It does the pre-screening, surfaces the relevant options, manages logistics. It saves the oncologist significant time. And regarding compensation, the model explicitly offers fair compensation models for trial-related work. It acknowledges the effort involved and aims to reward it appropriately.
So recognizing the value of the oncologist's role in trial participation.
Precisely. It's about reinforcing trust. The messaging acknowledges you've built trusted relationships with your patients. You shouldn't lose them after a referral. And you deserve support in providing the best care options without extra burden. It frames the network as a supportive partner, not another task.
Okay, so for you, the oncologist listening right now may be feeling overwhelmed, but wanting to do more with trials, wanting to be that confident decision maker or patient champion. What's the concrete path forward with this model? Our source lays out a pretty clear 3-step plan, right?
Yeah.
To keep patients and connect them to the right trials.
Yes, it's designed to be straightforward and actionable, providing a path to transform care without adding more to the oncologist's already full plate. Step 1 is simply join the network, create an account. This gives you access to that streamlined system for identifying the best trial matches quickly.
Okay, get in the system.
Step 2, connect with other oncologists. Use the platform's tools to easily facilitate those physician-to-physician consults or referrals we talked about. This helps ensure patients really understand their options and can consider trials fully. Collaboration in action.
Makes sense. Connect and collaborate.
And step 3 is shared care. This is about keeping your patients fundamentally within your practice, maintaining that continuity. You get a shared care co-pilot, essentially support to ensure your patient stays connected to you, even while they're actively participating in a trial elsewhere. You're always informed, always involved.
So join, connect, shared care. Sounds logical.
It's designed to be a practical pathway.
Now, the shared care network idea, it's not just about helping individual oncologists, is it? Our sources suggest it addresses major pain points for pharmaceutical companies and even insurance payers, too. Let's start with pharma. What's the core problem this network solves for them? We touched on recruitment bottlenecks.
Exactly. For pharma, the struggle is real and expensive. Patient recruitment delays drug approvals, sometimes by years. And they often have limited direct engagement with community oncologists, which is a huge problem because that's where the vast majority of cancer patients actually start their treatment journey.
Right. They're missing that crucial starting point.
They are. Pharma often relies on traditional advisory boards, usually with academic key opinion leaders or KOLs, but they themselves admit they often get rehearsed answers there. They miss the real-world, on-the-ground perspective from the community setting.
So how does the shared care network help pharma bridge that gap?
Through something they call the Shared Care Exchange Series. Think of it as a structured way for pharma to directly engage with community oncologists within the network. It provides a channel for real-time, unbranded feedback. Not sales pitches, but genuine dialogue. And it allows for scalable education on new therapies or trial designs.
Unbranded feedback, so honest insights, not just marketing speak.
That's the goal. This direct engagement helps pharma accelerate patient recruitment by understanding barriers better. It informs their trial design, making trials more practical for community settings, and it ultimately supports the adoption of new, effective therapies right where patients are actually being treated.
So it sounds like a way for pharma to stop, as the source says, guessing what oncologists think, and instead get honest conversations.
Exactly. Replacing potentially biased feedback from a small group of academics with broader, real-world insights.
What kind of insights are we talking about?
Things like actionable insights into trial fit, barriers, and real-world logic. Understanding why a certain trial might be difficult to enroll in a community setting, or what logistical support is needed. Insights they've often been missing. And crucially, this is done in a way that avoids being promotional, focusing purely on research and care improvement. The goal is driving real adoption and speeding up timelines.
Okay, makes sense for pharma. Now, what about the other side of the payers? Insurance companies, self-funded employers, HR leaders, what's their big challenge?
For payers, the problem is stark. Cancer care is frequently their fastest-growing cost category, #1 driver of total healthcare spend in many cases.
Wow, number one.
Yes, and often, by the time their members access advanced treatments or trials, the care is already too late, too expensive, and too fragmented. They often lack visibility into where their members are actually getting treated, and they don't have structured ways to identify those high-risk, potentially high-cost patients early on.
Leading to huge financial liabilities down the road.
Exactly. Unexpected, massive claims when things reach a crisis point.
So how does the shared care network offer an opportunity for payers?
It helps them steer care sooner toward better outcomes and lower spend. That's the value proposition. The network allows payers to proactively identify members who might be eligible for clinical trials. It can then connect them to high-value, appropriate oncologists, often locally. Essentially, it helps them offload treatment costs before spending six figures on salvage care by getting patients into potentially more effective, often trial-funded treatments earlier.
So for payers, it's fundamentally about cost containment, but achieved through better care coordination, making trials a strategic tool.
Precisely. It allows them to control rising cancer care costs and improve member outcomes simultaneously. It's not just about saving money, it's about better health. Plus, there's a risk mitigation aspect. Laws like the Consolidated Appropriations Act of 2021, CAA 21, actually place legal risk on employers and payers if they don't actively manage benefits and ensure access to appropriate care. Doing nothing is now a risk.
Interesting. So inaction has legal implications too.
It can. And the network can help by providing analysis, like looking at a payer's claims data to show specifically where members could potentially access better care, possibly through trials, often for less overall cost. And remember those stats, 65% of Americans are on self-funded plans. This impacts a huge number of employers directly. And cancer care is now the #1 driver of total healthcare spend. It's a massive financial and health issue.
It really paints a picture of a potential win-win-win for patients, oncologists, pharma, and payers.
That's the vision of a truly collaborative ecosystem.
Okay, as we start to wrap up this deep dive, we have to look at the alternative. What happens if things don't change? What are the real risks, the consequences of sticking with the old game, the status quo?
Well, if community oncologists and the system as a whole just continue down the current path, treating trials as that last resort, struggling with fragmentation, the consequences are, frankly, severe. And not just for the doctors, but devastatingly so for patients.
What does failure look like for the oncologist in that scenario?
The sources paint a bleak picture. They risk becoming perpetually overwhelmed and stretched thin, feeling frustrated and resigned because they know better options exist but can't easily access them. They might become afraid to refer, so patients suffer, holding back due to those fears we discussed, constantly burned by bureaucracy, fighting the system instead of fighting cancer, feeling disconnected and left behind as oncology advances rapidly. Ultimately, not being able to practice at the peak of their abilities, practicing at the top of their profession.
That sounds incredibly demoralizing for physicians.
It is. But the ultimate price, the true tragedy, is borne by the patients.
What happens to them if the system doesn't change?
They will continue to miss life-saving trials. Simply because the connection isn't there, it's too hard to find. They'll get stuck in standard of care loops, receiving older treatments even when a newer trial might offer significantly better hope. Many will lose hope as aggressive cancers progress, feeling like they've run out of options when potentially suitable trials exist somewhere.
Heartbreaking.
It is. Patients might be forced to travel or go nowhere, facing the immense burden of traveling long distances for a trial, or simply giving up because local access isn't available. And looking longer term, under-enrolled trials mean fewer clinical advances for future patients. The whole engine of progress slows down.
So the failure impacts today's patients and tomorrow's.
Absolutely. The ultimate failure, as one source puts it quite starkly, is when the system decides, not the doctor. Instead of oncologists shaping the future, driving the best care based on their expertise and patient needs, they become trapped, dictated to by a broken system. And that leads to frustrated doctors, underserved patients, and countless missed opportunities for life-saving treatments.
A powerful and sobering thought about the stakes involved. So I've really journeyed through the challenges today, the stark underutilization of clinical trials, the systemic barriers, the outdated mindsets, and contrasted that with this vision of a more connected, collaborative future through something like the shared care network.
We have. It highlights the friction in the current system and the potential for a smoother, more effective approach.
And for you, the listener, perhaps a final thought to mull over from this. If the power to change a really complex system, like cancer care, truly starts with collaboration and a shift in mindset, what vital connections or maybe outdated approaches are you potentially overlooking in your own field, or even just in your daily life? What missed opportunities might be unlocked by thinking differently, by connecting differently?
That's a great takeaway. It really makes you think about how deeply embedded assumptions, even well-intentioned ones, can become huge barriers. Questioning those is key.
Absolutely. How crucial these kinds of collaborative networks and mindset shifts are, not just in medicine, but really across so many complex areas. A truly insightful deep dive today.
Indeed. Critical thinking, that willingness to question the way things are done, is so essential, especially with the information overload we all face. Understanding these systemic dynamics can really empower anyone to seek out or even create better solutions.